we're going to do upper extremity. We're going to start with upper extremity. We might get to elbow, probably not, but we might get to elbow. We may just go through forearm. Elbow is going to be the most complicated thing that we're going to talk about in this section. So we'll spend a little bit of time on anatomy, but we'll get into projections, evaluation of images. So, you know, marker placement, image receptor positioning, shielding, collimation. I'm going to hammer collimation because it's just, you know, it's just important for a lot of different reasons, especially radiation protection. But I think that's the well, positioning and collimation are the things that people just are slacking off on more and more. So we'll talk about those. So we'll talk about the projections. There's fingers, projections, artifacts, you know, central ray location, specific things like in fingers, finger separation, hands, finger separation, which way we're going to rotate, and then touch a little bit on technique. So we're talking about individual fingers. Remember that our central ray location is always going to be in the center of the anatomy of interest. So the center of the anatomy of interest, if you look at your own hand, considering that we need to include, you know, adjacent joints and the bones, at least a portion of the bone, the adjacent bones, then you look at your finger and you say, well, the center of my finger is right about there, right? Which is nowhere significant. But if you consider that you've got to get that joint where the knuckle is, plus the distal portion of the metacarpal, then your centering point becomes pretty obvious, and that's your proximal interphalangeal joint. So in anatomy itself, what we've got is we've got a distal phalanx, a middle phalanx, and a proximal phalanx, and we've got interphalangeal joints that are identified by those, the junction between those. So that would be the proximal and the distal. That would be your metacarpal phalangeal joint, metacarpal head. So the things that you need to notice about your, you know, your long bones, these are considered long bones, even though they're not all that long. They are long bones because of the shape, right? If they're tubular in shape, then they're considered to be long bone, regardless of how long they actually are. So what you see is the proximal and distal ends are wider than the middle end, so they kind of have that hourglass shape. When you look at them from a lateral aspect, though, they're not. Okay, so the anterior portion is concave and the posterior portion is slightly convex. So we're going to use that to determine rotation. Okay, so just basic anatomy, and we'll get to all that, you know, the positioning here in a bit. So notice what you don't see on that one. Probably one of the more common, I'll call it a positioning error. Sometimes it's a patient problem. What do you not see on this particular image? Joint spaces, right. So your patients in a lot of cases, they'll give you a positioning error. You get them all flattened out, and then you step away from them. In a lot of cases, they start to relax and they'll bend their fingers. And next thing you know, you come out with something like that. You need to be able to evaluate that, make sure you get your hands as flat as possible before you make your exposure. Take a look at the patient and make sure that they're still, excuse me, they're still extended. Because the central ray needs to be parallel to the joint space. Now, this is something that you're going to have a tendency to miss on the test. So your central ray, back and back up, is going to be perpendicular to the proximal interphalangeal joint area, right? It's got to be perpendicular to that anatomy, but it has to be parallel to the joint space in order for that joint to be open. You see the difference between those two things? Okay, so it has to be parallel to the joint space for the joint space to be open. If it's not, if you've got an angulation on a central ray, or if you've got a bend in the finger, then what you're going to have is projection of the proximal over the distal, or the distal over the proximal, essentially. So you've got it's both of those really. It's the distal portion of the proximal phalanx projected over the proximal portion of the distal phalanx, right? And it closes up the joint space. That's important to keep in mind for a lot of different reasons. One is the joint space, but also fractures as well. If you remember back to first semester positioning, we were talking about the open mouth odontoid versus the Fuchs, and what did I tell you about the Fuchs?
Never useless?
Almost useless. Yeah, I had to swear off on calling it useless because I got in trouble for that, because it's still part of the protocol, and students were like, I'm not shooting Fuchs. Okay, well, if it's part of the protocol, you got to include it. And it's not completely useless, but it's useless adjacent, right? So it's really, really close to useless, but it's not completely useless. Angulation, if you put the angulation on your central ray, it can do the same thing as this, and that is close up the fracture line. So we see that also since we're doing upper extremity, we also see that in the scaphoid, right? So we do the dorsiflexion, and depending on where the potential fracture is, if we use a perpendicular central ray, you may be able to see the fracture. And then if we use the 15-degree cephalic central ray that we generally use with the ulnar flexion, then depending on where the fracture is, we may be able to visualize it. So the central ray has to be parallel to the joint space. It has to be parallel to the space created by the fracture as well in order to visualize it. Now, what if your patient can't straighten out their fingers? And I've got an x-ray of that in here that we'll take a look at. You can't shoot them AP. That's usually pretty rare. Sometimes people can't straighten their fingers out. Some people may have cut some of the tendons or the nerves, and it prevents them from fully straightening their fingers out. And you may have to shoot them AP. I had a patient, I may have talked about this last year, but I had a patient one time that he severed the tips of each one of the fingers. And in that, he did such damage to his hand that he had no control over anything else. What he did was he was mowing the yard with push mower, and if you've ever used push mower, if you let go of the handle, what happens? It dies. It dies, right? So he didn't want it to die, but he was mowing wet grass. So you mow wet grass, and what happens? Clogs up. This discharge port, right? So he held the handle, he reached down and started pulling the grass out, and he reached in too far, and he hit the fingers and took the tips of each one off. But it was such a violent interaction that it tore, the tendons everywhere. And so I asked him to extend his fingers, and he said, I can't. So I had to shoot him AP. So there is time for AP fingers. Generally we shoot PA, but there are times shoot AP. Patient can't extend their fingers, you may have to shoot them AP. If that's an extreme case, but if the patient has some sort of maybe rheumatoid arthritis or something, and they can't straighten their fingers, and you want to see how much joint space they still have, then you can still shoot them AP. Otherwise, generally PA. So that will be an example of one that, good luck with that one, really. It's a pin cushion in this guy's hand. You probably can't get a good AP, probably can't get a good PA. The hand is just destroyed at this point. You got pins sticking out all over the place. It's probably interop film, realistically. I don't see any casting material, splints, or anything like that. It's probably an interop image. All right, so when we're talking about fingers, individual fingers, your fingers are about as thick as they are fat. So there's no technique difference between PA, AP, oblique, or lateral. None of that. You just want to make sure you get adequate penetration. So your KVP, depending on the institution where you work, it may be as low as 50. That's really pretty low, considering KVP doesn't really control your contrast anymore, so most of your places probably should minimum 55, probably 60 kVp. So your MA, remember, might control your focal spot selection. If you set a technique with 300 MA or even 400 MA, you're not going to be able to select small focal spot. So you want to use 200 MA, whatever it is that you got to use in order to get to your small focal spot. Time, again, is pretty dependent on your system, but if you're using 60 kVp, it's probably going to be about a total of 1 mass. So you want to keep your OID as low as possible. SID is going to be 40 inches. It's just textbook positioning, and what you want to see are the distal portions of your metacarpals and all the way to the distal end of your distal phalanx. So you want to see cortical bone. Cortical bone, remember, is the outer portion of the bone. Cancellous bone or trabecular bone is the inner portion. And you also want to see the soft tissue. So soft tissue is important because what you may have is laceration that they're concerned might have also gotten into the bone, right? So make sure that you include the soft tissue, and when you're including the soft tissue, remember your collimators can be inaccurate to up to about 1/2 inch, right? So you want to collimate down to a point where you're going to include probably the distal fourth of that metatarsal, but also open your collimator enough that you include, direct exposure on the image receptor about 1/2 inch all the way around to make sure that you get all that soft tissue. So proper anatomy, evidence, collimation, open joints, soft tissue, make sure you separate the fingers so you don't get that soft tissue overlap. You want to look for a rotation. Most of your rotation is going to be external rotation because, again, you get the patient flattened out. You take your eyes off of them. Let's say you're shooting for the middle finger. That sounded kind of rude, didn't it? So index finger, we'll do that. All right, so you start, you get them all flattened out, everything's centered up, and the longer you leave the patient, the more they're going to relax, and they're going to bend their fingers, and you're going to rotate, the patient's going to rotate into external rotation. Okay, so considering everything that we talked about before, as we rotate up into external rotation, your hand is flat like this, right? But your bones, don't look at my finger, look at the shadow. Your bone is going to be thicker at the distal end. Let's say this is one phalanx, right? It's going to be thicker at the distal and proximal end, and it's going to have a bow in it. And I'm exaggerating this, but the back is going to be a little bit bowed. So imagine my finger with a fatter proximal and distal end, and it's got this bow. As we rotate, what you're going to have is a loss of the hourglass shape on the side that you're rotated towards, okay? So instead of having that hourglass shape, then what happens is you start to see the backside, bowed outward portion of the phalanx, and the further you rotate up, you're going to completely lose that hourglass shape, and it's just going to look like a bow, okay? So that's what you're going to do to evaluate rotation. You're going to look at the joint spaces. Are the joint spaces open? Do I still have an hourglass shape? If I don't have an hourglass shape, which way am I rotated? Most of the time on your upper extremity, because of, put your hand on desktop and just relaxed. And which way are you rotated? Just slightly. Externally, right. So this same thing is going to happen with a patient. Rarely are you going to have a patient puts their hand down and relaxes in internal rotation. It's just not. It's not natural. It takes effort. This takes no effort. That takes effort, right? So it's almost always going to be external rotation. So what you're going to look for is that hourglass shape. What you're going to see is increased concavity on the anterior side, decreased concavity on the posterior side. You're going to see increase in soft tissue on the anterior side. And you can kind of figure this out by poking on your finger as well. Where do you have more soft tissue? On the back side or on the front side? That's padded front side. Front side, right? So what you're going to see is more soft tissue on the anterior side. You can take a look at the fingernail as well, but fingernail's not always 100% accurate. It's kind of like belly button, center all your KUB on the belly button, and sometimes you're going to get that patient whose belly button is just hidden in the right place, right? So fingernail, you can look at that, but really what you want to look at is the concavity, convexity, and the difference in soft tissue. All right. So central rays should be perpendicular to the image receptor. Central rays should be perpendicular to that second, or in this case, if we're doing index finger. Second, second interphalangeal joint, but it needs to be parallel to the joint space, right, to keep it open. Anatomy included, we already talked about. Shape of the bone, we already talked about. Soft tissue comparison. Our obliques are going to be 45 degrees. Once we get to the obliques, then the anterior side, we're truly going to see an increase in concavity. The posterior side is going to be pretty flat, right? You're not going to have any concavity left. It's going to be flat, if not minimally convex. The direction of the oblique is going to depend on the digit, first semester positioning. 2 and 3, which way do we rotate towards? Medial side? You're going to miss that too. What side is this?
Lateral.
Yeah, it's the lateral side, right? We'll go from anatomical position, so it's towards the lateral side. 4 and 5 are going to be towards medial side, right? So keep that in mind. What also, your second year students, remember there's a difference between position and projection, okay? So what position is my hand in when I shoot a hand most of the time? It's prone, right? What projection is that? PA, right? So if I ask you position and I give you all projections, what is D probably going to be?
The only position for none.
None above, right? Don't miss that on the test, okay? All right, so position versus projection. Keep those in mind. All right, so now we've got 45-degree oblique. Look at the back side, it's straight. The front side has a concave appearance. We're starting to see that, you know, we've got a little sesamoid bone going there. All right, so what's wrong with those two? Well, it really depends. Without any kind of context going on there, you know, if this is a PA, then really essentially nothing. We've got the distal end, the proximal end. We've got, you know, the concavity looks the same, soft tissue looks the same. You can barely see the fingernail there. And then if this was supposed to be an oblique, is it? No, it's really a lateral. So without any kind of context, it's really kind of difficult to tell. So if this is an oblique, then it's a little bit over-rotated. I can tell you though that sometimes your obliques, especially when we get into the hands, are sometimes more diagnostic for displacement than what the lateral is. The reason I say that is because look at your metacarpal heads on this. It's almost lateral, right? What do you see? They're all superimposed, right? I'm not looking for fracture or anything like that, but they're all superimposed, right? So once you get into a true lateral, it's even going to be worse, right? So once we get into the hands, we'll see that sometimes oblique is a little bit more diagnostic than what the lateral is. So tell me everything you can tell me about that one. Okay, does the centering look okay?
Could be better.
Could be a little bit better. All right. Is collimation okay? It's a little over-collimated. Is it enough to, you know, really get upset about? Probably not. Just do better next time. So a little, you included just a little bit too much anatomy. Especially, you know, it's funny. Your basic anatomy, your sesamoid bones are under the thumb, but you know, people have them all over the place. You'll see patients who, you know, they'll have them behind the ankle. At first, you think they chipped off a portion of the bone. No, just a lot of people have sesamoid bones in places that are not normal. They're normal deviations. So, would that be a repeat? The answer is no, but this guy's got a funky finger. I don't know what happened to it, but look at this thing. It just goes up and squared off completely. It is broken, right? It does have a fracture there, but that just, I don't know what he did. Maybe jammed it. I don't know, maybe at some point cut the tip, I don't know. It's weird. So it's not ideal. It's not ideal. In an ideal finger, what you would have is, you know, they did a good job of separating the fingers, but what you would have is collimation down to about here. That should be dead square in the middle. Our collimation should end right about there, right? So it's not ideal, but it's, you know, it's not worth going back and re-exposing the patient. Why is there such high contrast? I don't know. It could be because we've got that much direct exposure to the image receptor. That can make a difference on the appearance of your image. That's why I'm stressing collimation. Can make a difference. So, image evaluation, we want to determine the accuracy of our rotation. You know, now we're getting into obliques. Look at fingernails, soft tissue, convexity, concavity. We looked at that a minute ago. On the lateral, you know, generally in lateral fingers, we're looking at each one separately. So we want to be able to separate the fingers as best we can. In Merrill's, I don't know why they still do this. You know, they've got that image of, let's say we took an image of the ring finger. And so try to extend your ring finger all by itself. That's the best I got, right? So I could see a portion of my middle phalanx and my entire distal phalanx. So what does Merrill's tell you to do with this broken finger? Is that a good idea? No. But where does the middle finger, what's it almost attached to? See what just happened? Can you see more of it? Less of it, right? More of it, less of it. So extend, you know, if you're doing the ring finger, maybe extend the pinky finger as well. You don't have to include the pinky finger, but, you know, include it or extend it, you know, then the ring finger will come with it. Are you going to be able to see the proximal end on a lateral? The answer is no. All of them are going to be superimposed. So again, a good oblique to include that proximal end, even if your protocol calls for AP and PA or AP and lateral, it might be a good idea if you see a fracture, you know, the proximal end or the distal portion of the metacarpal, to include an oblique anyway. Okay, so, you know, is that practice in medicine without a license? It's really good patient care, right? You see something, you should be able to, you know, pick up fractures, gross fractures by this point. You see a fracture, you just follow the instructions on the order and just shoot AP and lateral. Go ahead and shoot oblique. Make sure that, you know, good diagnosis is made. So on lateral, what you're going to see then, you know, make sure your fingers are separated. Which lateral depends on the digit. You're going to look now at the concavity on the anterior portion and convexity on the posterior portion. That's what I'm talking about. You broke that finger, and they want you to do that. How about no? Okay, so keep in mind the thumb, you know, kind of breaks all the rules. So the thumb is the first digit. We do things differently for it than we've done for any of the other fingers. First off, it's the only one we routinely perform AP, right? And that is because in order to get a PA thumb, what you're going to have to do is, you know, using the thumbnail for a idea of how straight it is. How much OID do I introduce in doing this? In a word, a lot, right? So we're going to shoot at AP, right? That's number one. Number two is we're going to include the entire metacarpal. And the reason for that is because we've got an opposable thumb And also, a lot of your thumb fractures are actually going to be of the proximal end of metacarpal. That's what we refer to as a bent fracture, or ski pole injury. And we'll take a look at a couple of those here in a minute. The difficulty that we run into is getting the patient into that position, right? So it doesn't really matter how you get the thumb into AP as long as you just do it, right? So what you'll see is some people will rotate the entire hand around like that and put it on the image receptor. And that's all well and good, that works, right? But the difficulty or the problem in positioning that way is that in a lot of cases people will do this and look at my hand. Okay, where's that going to put all of these bones and certainly all that soft tissue? Right on the metacarpal, right? So if you do it that way, just make sure that you rotate the patient. You're going to have to put some body English on this and get the patient to rotate out a little bit more and, you know, get the hand out of the way. So probably most common positioning error is just not getting the hand out of the way. Your buckies now, the wall buckies, are, you've got those removable grids in a lot of them, right? So you can pull the grid out and you can just do this, right? Right up against wall bucky, it's not a problem. So, you know, you can, on the table this way or whatever, just try to get that thumbnail flat best you can. And so the only one that we're going to include the entire metacarpal, all the way up to the metacarpal phalangeal joint. I'm sorry, the carpal metacarpal joint. So we're going to center then at the metacarpal phalangeal joint, which again is different than what we did on the fingers. The other things are that whenever we do a lateral of the thumb, all we're going to do is bend the fingers up. So your hand is flat, right? And with the hand flat, with the hand prone, then the thumb is going to be in a natural oblique position. So that's going to be positioning for your oblique of the thumb, is just lay the hand flat. But for the lateral, all we're going to do is bend the fingers, rotate the thumb up. In all three cases, we want to get all the way up to the carpal metacarpal joint, catch those bent fractures. Make sure that we don't have too much soft tissue overlap with the bones of the rest of the hand. Yeah. So carpal, metacarpal, carpal metacarpal joint, pretty good thumb. AP lateral positioning, probably could, you know, stretch that out a little bit more. So positioning errors. So is it, you know, what position is this? I don't know. Is it PA? Is it AP? Or projection is this? I don't know. We'll flip that back around and say AP rather than PA. So, and we'll put a dash in here just so that it doesn't look like it's saying AP of the hand. We'll say AP thumb with the hand not abducted. So we've got all that soft tissue overlap on the proximal end. So we've got soft tissue and bony overlap on proximal. Okay, kind of same thing here. Most common mistake. Again here, I don't know what position that is. Sometimes you have your patient position and they'll kind of stick their thumb out, like, you know, they're hitchhiking or whatever. So the thumb is not parallel. It's kind of, some people, their thumb kind of, you know, when they stick it out like that, it really bends backwards. Yeah, like that.
Come on.
So, and that's what you're going to get right there.
What?
So your Bennett fracture, we've got a couple of different things here. And we're going to assess both of these images as well as look at the Bennett fracture. So Bennett fracture is also referred to as ski pole injury, and that's a fracture of the proximal first metacarpal. So we've got it here, we've got it there. Okay. So what's the matter with these images? Exactly, we don't have the whole thumb on either one of them. And we've got what on this one? The rest of the hand. Now, these are pulled off a line, and when I get, you know, images like this, I don't know if they've cut them down, right? So I don't know if this was positioning. I don't know if this was just for demonstration. I just don't know. The ones that I really rail against are the ones that are obvious collimation issues. They just didn't collimate at all, right? So these, I'm not really going to rip on these images because I don't know that this wasn't a good thumb and they just cropped it just to demonstrate the bennett fracture. I don't know that this wasn't an entire hand that they, you know, the order was a hand, and the finding was that they had a bennett fracture and they cropped it down. I don't know. But if this was an order for a thumb, major fail. If this was an order for just a thumb, even major or fail, right? So, you know how to position for a thumb. Same thing here. Yeah, I did something similar to this about 3 years ago. In the original image, you can see a fracture line down through here. So pay attention to your surroundings, right? I threw something overhand, kind of hard, and I was too close to a pine tree. And on the follow through, I hit the pine tree and pretty much shattered my distal phalanx, and then split my proximal phalanx down to about there. Yeah, so, you know, wore a brace on it for a few weeks and finally, this was about 3 years ago, and there's still a little bit of tenderness right in this area right here, mild tenderness, but anyway, the small bones in the hands and the feet take about 6 weeks to heal up and at least 6 months to stop hurting. All right, so hand, kind of a lot of the same stuff in the hands as far as the evaluation goes is what we just talked about in the fingers. So with a hand, again, we're going to pick out where it is that we need to center based on what it is that we need to see. So our collimation needs to be opened up so that we see the distal portion of the radius and the ulna. We see all of the carpal bones, even though you know, this is a hand, not a wrist. We want to see the distal radius and ulna, all of the carpal bones, all the way down to the distal portion, the soft tissue on the distal portion of the third finger. So you look at your hand, that puts it pretty much right at the third metacarpal phalangeal joint. Remember, lateral versus medial. Somebody's going to miss that on the test. You know, when we're talking about lateral versus medial, it's always going from a position of anatomical position. So your basic positioning, central ray location, third metacarpal phalangeal joint. Probably the most common mistake I've seen, y'all should be past this by now, but first, second semester positioning, most common mistake I would see when I was a clinical instructor is students will go in and position for a thumb. They get so focused on, you know, collimation and central ray location, I put the hand up there like this and separate the fingers. Make sure you separate the fingers so you don't have soft tissue overlap. And the thumb is way out here, right? So what do? Well, this thumb now is sticking, instead of up like this, is sticking straight out like this, and the tip of the thumb is over here, right? Probably, again, most common positioning error I would see generally in first semester students. Take a look at your patient before you make your exposure, because sometimes your patients get a little twitchy, right? So you position them, and if they move their hand, their thumb off of or out of the light field before you make your exposure, reposition them before you make your exposure. All right, so again, if the patient relaxes and they bend their fingers slightly, then it's going to kick them into external rotation. It's going to close the joint spaces. We're going to see that difference in concavity versus convexity. We start to lose that hourglass shape. Notice that, especially on this little finger over here, the difference between the anterior and posterior side. They've also rotated themselves. Their fingers were probably separated enough that they shouldn't have had any kind of soft tissue overlap. but in that rotation, it projected that soft tissue onto each other. So we've got all the positioning errors there. Most likely, again, in this case, what happened was, you know, you position the patient, and then you go start setting your technique, and it takes you a little bit too long, and the patient, you know, loses focus, and they bend their fingers, they externally rotate, and that's what you get. So bent fingers, completely bent fingers. I don't know, again, some of these I just don't have the context for. I don't know if this was supposed to be a wrist and they bent the fingers up for the wrist and they just mispositioned, or the patient couldn't straighten the fingers out, or what it is. That's an extreme case of somebody with bent fingers. It does not look like this patient has rheumatoid arthritis. Anybody seen anybody with rheumatoid? Their fingers go in all different directions. They lose the articular ends. The bones look like osteoporosis, very dark. And they, you know, so that's not what this looks like. It looks like a good, healthy bone, just with fingers bent. That's a repeat. Okay, so again, this is what, there's good and bad in this, okay? So you remember whenever we do our obliques, and that's what this is supposed to be. You notice the backside is flat. The anterior surface is concave. It's oblique. It might not be a complete 45-degree oblique, but they did a good job of keeping the fingers parallel to the image receptor. You remember, we've got two different types of obliques. We've got the fan oblique, which is what this is. It keeps the fingers parallel to the image receptor, and that keeps the joint spaces open, right? And then you got the oblique where the fingers are used as a prop. With those bent fingers, what do you not see? Open joint spaces, right? So, you know, I'm not going to get hung up on what your protocols are. If your doctors are okay with using the fingers as a prop, it's a great way to get the fingers and the hand, really the hand, into a 45-degree oblique. Just have the patient make the OK sign. Have them, you know, sometimes you tell people, say make an OK sign, they'll do this. Okay. They don't need to be mashing their fingers together. Just have them touch, and it puts it in a natural 45-degree oblique, right? So if that's your hospital protocol, that's fine. If that's what your doctors want, that's fine. But if you're interested in seeing the joint spaces, which one do you need to select? The fan, right. So keeping the fingers parallel to the image receptor keeps that open. Now, you know, it's good, healthy bone. Why does it look kind of dark and washed out? Well, it could be because the thumb is sticking out here, and even though they did a good job of collimating to what's on the image, we still have a lot of direct exposure to the image itself, right? Which can mess up your contrast. Again, KVP is not going to do that, but your collimation can, okay? So is that worth repeating? Again, probably not, but next time, remember to bring the thumb in just a little bit and eliminate some of that direct exposure. Already looked at that. So we already talked about the oblique fan versus, you know, using the fingers as a prop. But the lateral, the same thing applies. So we've got two different laterals. That's with the fingers in extension, and then we've got the family. So that's both of those. So, well, that's oblique, really. And these are fuzzy. Sometimes whenever I save them, they save small, and when I magnify them up, it just kind of gets fuzzy. So 45-degree oblique, the fingers extended, our fan lateral, looks like that. So let's assume that's supposed to be an oblique. Okay, not a PA, but oblique. I assume it is because, you know, you've got the open joint spaces. How's it look?
Under-rotated.
Under-rotated, right. It's a little under-rotated. 2 PA. Okay, so what about that one? The rotation is maybe a little over-rotated, but what else do you see? You got soft tissue overlap, right? Do you see the joint spaces? Not really. Did they use the fingers as a prop? Doesn't really look like it. I mean, you see joint spaces in the thumb, right? Fingers are bent, but they don't have that okay look to them. In the thumb, the joint space is fairly well open. I don't know exactly how they did this, to be honest with you. All right, so common fracture, boxer's fracture. Again, your oblique sometimes, even though this is kind of under oblique, the boxer's fracture is a fracture of the distal portion of the fifth metatarsal. And it happens in most cases because somebody punched something. In my experience, it's every single time somebody punched a wall. Every single time somebody punched a wall. The oblique is going to be more diagnostic than what the lateral is going to be. In most cases, this one, we've got a pretty significant anterior bend to it. PA, can't really see where it's going. On the oblique, you can. You could probably see that on the lateral, but you're going to have superimposition of all of the other metacarpals on top of it. So, good oblique, and maybe slightly under-rotated. So one other thing that we're going to be looking for on oblique is the proximal intercarpal joints on the lateral side, the thumb side, are going to open up and they're going to close on the medial side. Okay, so you look at your PA, you got superimposition and you got superimposition. And then on the oblique, you got increased superimposition, and that's on the medial side, and decreased superimposition on the lateral side. Okay, so those, again, are evaluators you're going to look for. Never seen this before, not in clinical practice, but that is what we refer to as polydactyl. They got one too many fingers, right? Actually, one too many thumbs in this case. Also, kids, this is very, very young. You can see the start of the formation of one of the carpal bones here. That's mom's hand. They don't have a thumb sticking in the middle of the arm. But you just don't have any bones in the wrist yet, really, and all your articular surfaces are not completely formed yet. Okay, so what about that one? How's it look?
Something weird.
A little weird.
It's pediatric.
Okay, so as a kid, still, we've got open joints or epiphyseal plates here, right? We've got a little bit of bend in the fingers. Again, is it enough to really get in a twist about and repeat this patient? The answer probably no. You know, what is the patient's history? Where they hurting specifically? And if it is in that ring finger, can we see any kind of issues on the oblique or the lateral? But that by itself, you got a little bit of increases, soft tissue superimposition. Is it a repeat? I'd say probably not. Bone age is, I just included this for grins. Assuming that this is the same person at 1 year, just the progression of the bone growth. By 12 years old, they've got pretty much all their carpal bones. At 1 year, they've got started two. It's kind of cool to see. Let's see. So, okay. Yeah. I don't remember where I found that, but I thought it was pretty cool. The things that will show up, especially in the digital world, that just weren't an issue in, when I first started my career. Wet hair. Who would have thought, 30 years ago, that wet hair would show up on an X-ray? It will not. Manicure things. It's weird. All right, so good fan lateral. When we use fan lateral versus extension lateral, if you're interested in seeing the fractures, you know, if you get a hand x-ray and you notice a fracture in one of the digits, then what you want to do is fan lateral. At least fan that one digit, right? At least get it out from under the rest of them. Even if your hospital protocol and most of the techs do extension lateral, try to get that one digit out so that, you know, you can make a diagnosis on that fracture. The problem with the fan lateral though is if you look at your own hand, you take your fingers and you start to do this with them. What happens to the soft tissue in front of your hand? It kind of bunches up, right? So the extension lateral is really good for demonstration of foreign bodies. So somebody works with metal or whatever, and they come in and they've got, you know, some sort of laceration in the middle of their hand, and they're concerned that some sheet metal may be in there. That's your go-to move, would be the extension lateral. Fan lateral, fractures of the digits. Extension lateral, foreign body. Probably the most common two mistakes I've seen in first and second semester students in doing lateral hands is, you know, you form your own instructions for the patients. You know, I want you to put your hand up there like you're karate chopping it, right? So they put their hand up there, sure enough, like they're, you know, doing a karate chop. And you step behind the control panel, you make your exposure. And what kind of positioning error do you have? Thumbs pointing straight up, right? So that's fine for explanation of how to position, just make sure you put the thumb down. So that's one, and the other is just like on the hand, what will happen sometimes is the student will, you know, position the hand, and they get so focused on the hand itself, they forget all about the thumb. And they practice good collimation, but the problem is they collimate to the hand and not the thumb, they clip the thumb right off. So make sure you pay attention to those two things on your laterals. Okay? Any questions so far? How long are we here?
10:45.
It doesn't tell me anything. I don't know what time we started.
Like
I know. We'll go through the wrist. And there is one kind of complicated thing on the wrist that I won't get through. I don't want to throw two complicated things at you. The elbow is, again, most complicated thing we're going to do. So normal routine wrist is 3 view, but we do have some specialty views of the wrist we're going to talk about. So probably I would take the technique out of here. 50 kVp is really pretty archaic. You're going to start at 60 kVp. So most of the fractures of the wrist are not going to be of the wrist bones. They're going to be of the distal portion of the radius and the ulna, right? So you want to make sure that you include about 1/3 of the radius and the ulna. Most of those fractures are going to be the distal, 2 or 3 inches. So your Colles fractures, your Smith fractures, your Torres fractures, you know, the buccal fractures that you're going to, green sticks that you're going to see in kids. If you do have a fracture of the wrist bone, most likely it's going to be scaphoid. Okay. So your test questions on scaphoid, sometimes I'll ask which one is most commonly fractured. That's going to be scaphoid. Sometimes it will describe the position of the scaphoid. Which bone is most commonly fractured? That will be the lateral, proximal, or where is scaphoid located? That will be on the lateral side, proximal bone. So scaphoid most commonly fractured, and it can be fractured in one of a number of different places. We'll take a look at it here in a minute. We want to look also not just at the bones, but also at the soft tissue. We talked about this in the first semester, but that's been a long time ago. A fat stripe is dissimilarity in soft tissue. Okay, so you got fat, you got muscle, you got tendons, ligaments, and all that. And each one will show a different density, just slight density. And a fat pad is, or a fat stripe, is that difference in radiographic density. Okay, so the fat pad should follow the contour of the bone. So sometimes you can have a fracture, you can't see it. You just, like, I don't know, you may break your elbow and you go in for an x-ray, they can't see it, but they want you to follow up with an orthopedic surgeon in a week, and in a week, they can see the fracture. Okay, so sometimes it doesn't show up, but there are telltale indicators that there's a fracture there. You're gonna have swelling, and that's where the fat pads come in. So let's say you got a fracture of the scaphoid. We're certainly going to look at the scaphoid, but we're also going to look at that scaphoid fat pad. So if we have enough, refer to it as an effusion, it's just a collection of fluid in the joint space that distorts that fat pad and it bows away from the joint, that's a good indication the patient's got a fracture there. Okay? So we want to be able to visualize those. All right, so really can't see it, but that would be, again, right up here. We should be able to see a dark line, and if it's even straightened out instead of paralleling, essentially this joint space area, then it would be an indication we've got a fracture there. So RPA, we want it under rotated. We want to keep the shoulder, the elbow, and the wrist in the same plane. We did this first semester. You've probably gotten away from it because that's a long time ago, and you probably aren't seeing a whole lot of people do this, but we're going to run through this little exercise one more time. So what we want to see is we want to see the the ulnar styloid process in profile. What does profile mean?
A picture, a view.
Sticking out to the side somewhere, right? Think of a mugshot. What do? Some sort of frontal view and a profile, right? So I want you to put your hand down on the desk. We usually shoot PA for a wrist. We can't shoot AP, and we'll talk about that here in a second. All right, and feel that knot on the medial side. That's your ulnar styloid process, okay? So where's it sticking out? Kind of up, isn't it?
Yeah.
Okay, it's sticking up. So how are we going to see it in profile if it's sticking straight up?
Not PA.
You're not. Well, you're not, right? If you got your hand down like this, you position your patient. I don't blow my knees out. Y'all will learn one day. The knees don't last forever. I remember it was a few years ago. It's going. A few years ago, I was showing how we were in positioning class, a second semester positioning class. We were doing interpupillary line perpendicular for the lateral. And I used to kneel down. I say, take your pen and put it in front of your face like this so that you can use it kind of like a plumb bob. You might remember this. I still use that, but I used to squat down and get at table level. And my knees were killing me. I stood up and I said, y'all just witnessed the last time I ever squat down in class again. And sure enough. All right, so you position your patient for a wrist and you just tell them put it on the image receptor like that. Their ulnar styloid process is sticking straight up. You're not going to see it in profile. So I want you to hold on to your ulnar styloid, put a 90-degree bend in your elbow, lift it up shoulder level, and tell me what happens. It disappears. It rotates out so that you will see it. Yours didn't? No? You got both arms stuck in your shirt.
No.
All right, put it back down at the table level. You feel it? Mm-hmm. And some people have, difference in anatomy. Now pick it up shoulder level, just slowly. Whoa. You feel it? Kind of weird, isn't it? All right, so so when you position, we stress that on a lateral elbow, right? Everything in the same plane. We'll get to that next week. But you need to be doing it on your wrist as well. It's probably not a deal breaker as far as positioning goes. If your patient just can't do it, maybe shooting it, with a portable in the ER, probably not as important. But in an ideal situation, you want to get everything on the same plane. Make sure that you can see that styloid process. All right, so we want to see PA, everything in the same plane, fingers bent but not clenched. Okay, so why do we bend the fingers? Well, it's because if your fingers are flat, a little more sturdy, fingers are flat, what do you see under my wrist? A gap, right. So if you bend your fingers, though, then it flattens that out, right? So it decreases OID, kind of spreads your carpals out, your carpals out, flattens them out, reduces OID. If you clench, though, you're right back to where you were before. You make a fist, then it's going to re-elevate those. So you want to bend the fingers, but you don't want to clench them into a fist. Otherwise, you'll wind up with that increase. All right. So now this question right here is something we talked about again first semester. And I posed the question. I'll draw it out first. Your carpal bones are conical in shape, meaning they're kind of cone shaped. So the anterior portion, since we do PA, anterior portion's right there, they're shaped like that. How does your divergent ray, is your focal spot this big and your divergent rays coming in like this? Or is your focal spot this big and your divergent rays coming out like that? It's like that, right? So, if this is the anterior portion, if we flip the bones around, we shot them AP, the focal spot's there, which one more clearly and closely follows the divergence of the central ray? AP. So you're going to run into questions at some point that asks you if your interest is the carpal interspaces. What position should you put the patient in? That's a projection. What position? Supine. It should be supine. Your projection should be AP. Right? So, my question in your first semester was, why don't we just do them all AP? That's my answer. I have no idea. Why we don't do them AP anyway? Probably get a better image. I don't know. You don't have to do the whole finger thing. If they're AP, you shoot them AP, they're gonna extend their arm out, put everything at the same level, right? I don't know. I have no idea. Industry standard, kind of stupid. All right, so central ray is going to be to the mid-carpal region. Again, fingers bent. Yeah, that's the same image. Was it supposed to be a wrist? It's supposed to be a hand? I don't know. Most of the time, again, our rotation is going to be external rotation. If we get internal rotation, we see different things. So this might have been an AP instead of PA. It might have been an AP with some rotation towards the medial side. That's where we see pisiform. Most of the time we shoot PA, and with external rotation what we see is a scaphoid, but in this case what we're seeing is pisiform. So if you happen to see the pisiform on PA, then what you've got is some patient who's somehow internally rotated. Okay, so radial flexion, radial deviation, ulnar flexion, ulnar deviation. Different textbooks come at this from different orientations. Most of the time, if there's conflict between different textbooks, major textbooks, that's not going to be a registry issue, okay? So when we're talking about radial flexion, it's flexion towards a radius. Some people refer to that as radial deviation. Some will call it ulnar deviation. Since there's differences of opinion there. You're probably not going to see it on the registry. So just assume flexion and deviation mean the same thing. That's towards, flexion towards. Okay, so generally we don't see radial flexion. We see ulnar flexion towards the ulnar side. This is radial flexion. What we've got is scaphoid and the bones on the lateral side of the wrist, because we're anatomical position, compressed, and it spreads out on the medial side of the wrist. Okay, so the purpose for those two flexions is to desuperimpose the bones on those specific sides of the wrist. So what we're going to look at is scaphoid fat pad. Usually our rotation is going to be towards, external rotation. We want to be able to visualize the ulnar styloid. The scaphoid with minimal foreshortening is still going to be foreshortened. The scaphoid is in the wrist and it's kind of like so. All right. So you got different portions of the scaphoid. The distal portion of the scaphoid is going to be a little bit foreshortened. And if fractures are across that distal portion, they're going to be hard to see. So minimal foreshortening is still going to be some foreshortening there. We want to include the distal forearm because that's where most of your fractures are. So that's what it should look like. You got a good ulnar styloid process sticking out there. Scaphoid's got some superimposition on it, a little bit of foreshortening. You can't really tell that, but it does. Now, take a look at your patient's anatomy. Some of your manual laborers, like construction workers, swing a hammer all day. They got these great big fat forearms, okay? That can affect the positioning of your wrist and of the elbow. So we're going to talk about the elbow next week, but it can affect the positioning of the wrist. So you see this line right here, and then you see this line right here. That's not abnormal anatomy. That's anterior and the posterior portion of the radius, okay? And they should be superimposed. And what happens in some cases with somebody with a great big fat forearm is that you put the forearm down, you say, well, I gotta get the wrist in contact, and you kind of push the wrist down, and that's what you get. In those cases, take a look at the patient's anatomy. If they got those great big forearms, then what you might want to do is position the patient where that fat portion of the forearm is off of the image receptor. Now, it's not going to put it in the middle of the image receptor, but it's going to avoid something like that. Okay? So don't elevate it, just, hang it off. All right, so our oblique is going to be external rotation. It's a lateral medial projection. The hand, the elbow, and the shoulder still all in the same plane. It should open the carpals on the lateral side of the wrist. Lateral side of the wrist is the thumb side. What's over there? Scapula, the bone that's most commonly fractured. Unfortunately, we're going to have, because we're going to externally rotate, we're going to have increased NOID, slight loss of sharpness or recorded detail. But what's going to happen is that the scaphoid, again, is kind of, it's like that, right? And as we oblique it up, it becomes more parallel to the image receptor and perpendicular to the central ray. So we get less foreshortening. Therefore, the oblique shows the bones on the lateral side of the wrist, but especially the scaphoid. Okay, that's the main thing that we're going to be looking at on the oblique. Okay. All right, so we already talked about that. Wrist flex, no more than 15 degrees. Scaphoid tuberosity and profile, externally rotate 45 degrees. In this case, you can use the fingers to support the wrist because we're not looking for the joint spaces in the fingers. And it should look like that. So scaphoid, we got superimposition on the medial side, desuperimposition on the lateral side, specifically looking at the scaphoid. So lateral wrist, Most of the time it's going to be lateral medial projection, arm elevated, everything that we've already talked about. Central raise should be to the mid-carpals, include the distal 1/3. All right, so for wrist bones, what we want to see is we want to see the radial and the ulnar styloid processes superimposed. So again, put your fingers on those two. And what do you feel? If your hand is straight up and down, what do you feel? Are your fingers on top of each other? No. No. Your radial styloid process is going to be anterior to your ulnar styloid. Okay? So this is just, you know, this is not a textbook thing. This is kind of my cheat code thing. Is that if you use the hand to determine whether or not the wrist is in good lateral, and the wrist is in a good lateral position as to be determined by whether or not your radial and ulnar styloid processes are superimposed, is your hand a good tool to use? No. No. Mostly. So the wrist has to be lateral. In order to get the wrist lateral, then you may have to slightly supinate, not superimpose, but supinate the hand. And when I mean slightly, I'm talking about 5 degrees. It's very, very subtle. So you can use the hand and then slightly supinate, just maybe 5 degrees, and you get a good lateral wrist. Most of the time, anyway. Okay? So the answer to the question is, what do you use to make sure you get a good lateral wrist? One of the answers is hand. Hand bones need to be good lateral. If you answer that, you're going to get it wrong. Okay. So what we're going to look for here now is pronator fat pad that's on the anterior side of the wrist. We're going to look at the lunate. What does lunate sound like? Moon. It sounds like moon, right? It's that bone in the wrist. If you've seen a good wrist, it looks kind of like a half moon, right? So if it looks like a half moon, you probably got a pretty good lateral wrist. Slight pronation projects the scaphoid a little bit anterior to the pisiform. So what you want to see is the distal portion of the scaphoid and the pisiform perfectly superimposed. If you over supinate for that lateral, what's going to happen is the pisiform is going to go anterior, scaphoid's going to go posterior. So if you don't have that superimposition, then you over supinate it. Okay? So it looks like that. This round thing right there is the pisiform. Okay? It's just easier to see on the drawing. That's your scaphoid. So the very distal portion of your scaphoid should be superimposed on your pisiform, just like what we're seeing right here. You got scaphoid, pisiform, good lateral, right? Notice the hand is not perfectly lateral. And pronator fat pad is right here. Should indicate whether or not you might have a subtle fracture of the distal radius. Okay, so same stuff. Okay, so fractures of the scaphoid itself. So what we got with the scaphoid is our difficulty in seeing the fracture of the scaphoid is dependent on where the fracture is. So we've got 3 different places. We got the waist, we got distal, and we got proximal. So if it's going across the waist, it's probably going to be that 15-degree angulation that we use for our I'm going to call it a modified Stetcher method. So if you remember back to your Merrills, you've got 2 different things. You've got the 15-degree cephalic angulation, or you place the hand in the wrist on a 15-degree sponge, right? And you've got the ulnar deviation. Those are 2 separate things. Why they haven't made a modification to those 2 things and put them in as a single view, I don't know. I just don't know. Because every hospital I've ever worked in wanted you to do both of those things. Ulnar deviation to decrease the superimposition on the the bones on the lateral side of the wrist, especially scaphoid, 15-degree angulation to put the central ray parallel to what is probably the most common fracture site, which would be the waist of the scaphoid. Okay, so it can be broken in one of three places. That's just a compromise to hopefully be able to visualize any one of those three, right? The 15-degree angulation for the Stetcher method with ulnar deviation just to desuperimpose all those things. All right, so we'll run through fractures real quick and then we'll call it a day. All right, so Colles fractures, Smith fractures. You see these most of the time in your older patients. Somebody falls down, they catch themselves, and the difference between the Colles and Smith fracture is which way is the distal fragment going, right? So if they catch themselves, the distal fragment is going posterior, then that's what we refer to as Colles fracture. And if it's going anterior, that's what we refer to as Smith fracture. Fundamentally the same thing, it's just how far did the hand get, you know, patient's falling down, did they get their hand out to catch themselves? If they did, that's Colles fracture. If they almost did, it's Smith fracture, pretty much. All right, so very common. Green stick fractures, remember, occur in kids. And green stick fractures just mean that it's not broken all the way through. So just like breaking a green limb off of a tree, you know, you go to break a twig, and when you snap it, because it's still, you know, a good living limb, it breaks on the top side and it doesn't break all the way through. Right? You got to cut it or twist it or something like that to get it to break off. And that's why we call it a green stick fracture, is because kids' bones can break on one side and not the other. A very common, probably most common I've seen, is what we refer to as a buccal fracture or a torus fracture. And most of the time I've seen those have been in the wrist. So kid falls off a bike, trampoline. I've probably seen trampoline more than anything else. Kid falls off a trampoline, catches themselves, got a torus fracture. All right. But there are some other ones as well. You know, looks like bird shot. Somebody got shot, a shotgun, accidental on purpose. I don't know. I've seen both. Probably the funniest case I ever saw. This was not local, so but a man and a wife got in a fight, argument, and she got mad enough that she pulled a gun on him, and it was a 30-30, a lever action rifle. And he went to reach to take it away from her. She shot him in the hand, destroyed his hand, just absolutely destroyed his hand. He took it away from her, racked another round into it with his other hand, shot her in the foot. And the ER doc had a sense of humor. He put them in the same ER room, side by side. You know, by the time we got to him, you know, we were taking X-rays on him. He recognized how stupid this whole thing was, and he had a sense of humor about it. She had none. If she'd have had the gun, she'd have finished the job. I guarantee. So anyway, gunshots just do terrible things to bones, extremity work. So this is an external fixator from a gunshot wound. Looks like a bird shot. Could have been accidental, I don't know, but the purpose for the external fixator is to give stability. It's kind of like an exoskeleton to give stability while the bones heal up. That wrist is probably never going to bend again. I don't see any distal radius. He probably lost, I don't know, a couple of inches off his forearm. So, you know, his suits aren't going to fit right anymore. So ulnar deviation we already talked about. That's what that is, ulnar deviation. With or without, you can't tell from that image whether or not there was 15-degree angulation. That's what scaphoid fractures can look like. Fixation of scaphoid fractures. Pisiform, we kind of talked about that. Once in just a blue moon, you may get a request to visualize pisiform, and just realize that that is almost exactly opposite from a scaphoid. So it's going to be AP, it's going to be an external or kind of internal rotation from AP, and what we're trying to do is project the pisiform up and away from the rest of the wrist bones. Or I guess it's down and away from the wrist bones. Okay? Any questions?